Let me just kind of show you a little bit, and this is just really the device units. It's very just like a hand size, small units, powered by 9 volts battery. It's a it's portable. It's easy to use. I can just clip on my belt and I can, do the therapy at the same time. So it doesn't have a lot of advantage. Um, and then even you can do it at home for certain and disease conditions. The Transport 2 study is funded by the National Institute of Health back in 2018. At that time, there's quite a bit of small, a small single center proof of concept study, all showing transcranial direct current stimulation shows very good promise to help with a stroke patient to improve their motor function. By that time, most of the study was capped their dose at a 2 milliamp. The results kind of variable, inconsistent. And then my lab and also, Dr. Godfrey Schrock, from Boston, and then we did a several study where it shows the, doubling the dose to the 4 milliamp. It's safe, it's tolerable for stroke patients. And at that time, I also have a lot of concern. Maybe the 4 milliamp may not be tolerable for patient or healthy controls. And also there's data suggesting using the high dose seems more effective to increase or inhibit the cortical excitability, and depends on the modality of the and the device. So we thought that would be great, and we can do a big study, and so we can see which group is doing better. Our hypothesis at that time is where the 4 milliamp is better than, and the 2 milliamp and better than the sham and the stimulations. The sham stimulation will receive 30 seconds, just give a little perception so the patient doesn't really know which group they are in. Interestingly, we actually, and I did a survey at the end of this, asked them to make a guess, and also asked the person provided therapy also make a guess. In the end, they really don't know which group they're in. Of course, you can't just stimulate the brain, and you also have to do the task-based therapy, and together, to let the brain to rewire. So that's what I'm showing is we're doing called constraint-induced movement therapy, which proved to be effective. And, about 20 years ago, the concept is really, assume I'm a stroke victim, my right hand is affected side, my left hand is good, but now I have to force to use this one. But how I can force this, I basically to constrain with my good hand with a big glove. So again, I say I can't use my left hand, I have to constantly use my right hand. At the same time, I'm doing the anodal stimulation to boost cortical excitability on the side I have a stroke. The contralateral side, believe it or not, after stroke actually overactivated. I'm actually called a cathodal stimulation here to inhibit, and the peripheral, and wear the glove. I can't use my good hand. So every day I have to force to use my affected hand. So stimulation was 30 minutes, and the whole rehab therapy is a 2-hour active time. Means you go to the bathroom, you have to make up the time. This is almost 5 times of the therapy most stroke survivors receive from their rehab, from rehab session. Because typical session 45 minutes, the act time they receive is really just about 20-25 minutes. But we have to do 120 minutes active time. And we do 5 sessions per week, and for 2 weeks, so total 10 sessions. And then we look at the outcome immediately after 10 sessions for the day 15, day 45, which is 30 days, and then day 105, which is 90 days after the intervention. So we can assess for a shorter term and a long-term outcome. But the results, there are some part that was really came out as we expected, but some results come out as unexpected. The part I expected is the proposed intervention was safe, tolerable, and it's feasible. We really only have 2 patients withdraw from the study, and despite all the challenges from the COVID. The part that really surprised to us is we initially made a hypothesis the 4 milliamp will do better. At the same time, be safe and tolerable. But what we find out is 3 groups, they all improve. There's no separation and at a day 15, which is our primary endpoint. Even on the day 45 and day 105, there's no, and they continue to improve. But there's just no separation among the 3 groups. So I have to say a little bit disappointing, but that's based on predefined study. And we hope to do a further analysis to see if we can, and we can dig a little bit more. At this moment, because it is a neutral study, we can recommend to a stroke patient to use the transcranial direct current stimulation. But I would say, we do confirm the CIMT, constraint-induced movement therapy, the rehab therapy, which everybody received, is actually quite effective. Most of the occupational therapy or physical therapy actually, and they know how to do this. But it is very intensive therapy. Not all the clinics that provide therapy. So for stroke survivor, you should talk to your therapist and to consider and to receive a CIMT therapy. It's quite effective. We are here to present the data, and there are a lot of other, brain stimulation options. This is just called a direct current stimulation. There's alternate current stimulation. There's a magnet stimulation, and which use a magnet field to generate electrical pulse. My labs also focus on ultrasound stimulations. There are other, invasive brain stimulation as well. So there's a lot of options. At the end of the day, I believe it's a technology, patient selection, and outcomes, and that will make us successful.